Uh, good morning, everyone. Today we are here for a CGR on thrombotic microangiopathy, a case of thrombotic microangiopathy in a patient with malignancy. I'll be presenting this CGR under guidance of Dr. Sharon Kandari, ma'am. In patient particulars, we are presenting a patient, 54-year-old male, resident of Ganganagar, Rishikesh. Patient was admitted to us with on 20th of Jan 2024 from ED, and patient is still admitted with us. He's businessman by occupation, and history was given by the patient himself, and reliability is good. Patient is non-diabetic and non-hypertensive. In March 23, patient was diagnosed with a case of metastatic carcinoma pancreas and was found to be BRCA2 positive. And at the time of diagnosis, only patient had metastatic lesions in the liver and lymph nodes. In July 23, the patient was started on chemotherapy. The regimen was nanoparticle paclitaxel based and gemcitabine based regimen, and total cycle was continued for total around 7 cycles. The PET CT done on 31st of October last year showed a good response with complete resolution of the liver lesions, and the baseline creatinine available to us was 0.6 in December 23. Before the presenting illness, patient had already received around 7 cycles of chemotherapy as on 6th January this year, and patient was admitted into nephrology IPD with complaints of nausea, vomiting, and decreased appetite for 2 weeks, facial puffiness, pedal edema for 10 days, decreased urine output for 10 days, and breathlessness on exertion for 7 days. History of presenting illness in detail: the patient's nausea and vomiting. Initially, patient confused these side effects as a part of side effects of chemotherapy, but later on the side effects didn't resolve with the usual routine medications. And the edematous illness, which involved the entire body of over for 7 days, with associated with the decrease in frequency from 5 to 7 times initially to 2 to 3 times per day. And from last 2 days, patient was complaining of shortness of breath. The management done outside on 18th of Jan, patient was consulted by physician for his edematous illness and decreased urine output. And patient was advised diuretics and tablet Remipil, following which urine output further decreased to 2 times per day with minimum of the volume. Now, in past history, there is no history of hypertension, diabetes, blood transfusion, tuberculosis, or jaundice. In family history, there is a family history of breast cancer in younger sister and lung cancer in mother. Both of them were BRCA2 positive. Personal history: patient is non-smoker, consumes mixed diet, normal bowel habitus, and is married. Relevant negative history: there is no history of frothing of urine, hematuria, cola-colored urine, severe abdominal pain, joint pain, rash, oral ulcers. And there is no history of yellow discoloration of eyes and skin, no history of flank pain, lithuria, feeling of incomplete voiding. And there is no history of chronic NSAID abuse, over-the-counter painkillers, or alternative medication abuse. On 20th of Jan, when the patient presented in ED, patient was conscious oriented, had a pulse rate of 90 per minute and was regular, blood pressure of 148 by 1115. Initially, patient was non-hypertensive with a respiratory rate of 30 per minute and saturation of 94 at room air. On general physical examination, pallor was present and patient had bilateral pitting edema, bilateral pitting pedal edema, grade 3. There was no icterus, cyanosis, clubbing, generalized lymphadenopathy. Nasal, oral, and nasal cavity was normal, and no joint rash or joint swelling or tenderness. In systemic examination, the prominent findings were bilateral crepes were present in bilateral infrascapular, infraaxillary region. The rest systemic examination was within normal limits. Seeing the previous records for the patient on 6th of the Jan had HB of 8.7. Prior to that, patient's HB was around 10.2 in December last year. Patient had progressive decrease in hemoglobin initially, and it was associated with progressive rise in creatinine. Baseline creatinine available to us in December was 0.6. And after that, patients on 6th Jan had a creatinine of 1.3, which increased to 1.5, then 1.9 and 5.2 on presentation to us at ED. And at ED, a provisional diagnosis of acute kidney disease was made that patient had renal dysfunction for 14 days associated with edematous illness, anemia, and hypertension. And patient was admitted to nephrology ward for further evaluation and management on the same day. Chest X-ray done on first day shows features of fluid overload. You can see bilateral curly B lines and bronchovascular enhancement. On first day, as the patient was oligoanuric with fluid overload with the saturation of 90% at room air, hemodialysis was initiated in view of fluid overload via left femoral double lumen catheter. And urine dipstick done on the same day revealed 2 plus protein, 3 plus RBCs, nil leukocytes, nitrate, and were negative. And bilateral USG KUB screening showed right kidney of 9.5 centimeters, the left of 9.8 with bilateral preserved CMD and normal parenchymal echogenicity. So provisional diagnosis at ward was kept as acute kidney disease, getting stage 3 in a patient with already metastatic CA pancreas with hypertension, likely secondary with anemia. Dissecting further the acute kidney disease in a solid organ malignancy, keeping differentials of pre-renal, renal, and post-renal. We ruled out pre-renal cause as there was no signs of symptoms of extracellular volume depletion and serum calcium was normal. And in post-renal, USG KUB screening done at ward and also from the radiology department revealed no hydronephrosis, calculi, or bladder clots. We left the renal being the more etiology for this condition. In renal, again the differential was compartmentalized to glomerular, tubulointerstitial, and vascular. In glomerular, since patient was having neoplastic, already a neoplasm, the possibility of paraneoplastic associated with CA pancreas was less of a possibility since the disease was already under control. But the prominent features favoring the glomerular etiology was urine RM already showing active sediments, and patient was having hypertension with oligoanuric status. In tubulointerstitial part, since the patient had received diuretics and ASARBs and following that patient was having worsening of renal function and decrease in urine output, that possibility couldn't be ruled out also. In vascular part, we have more of the differentials favoring that urine RM, although was showing active sediments, there was hypertension, oliguria, but there was prominent anemia, it was worsening, and thrombocytopenia, which was also worsening along the course. During the hospital course, the patient remained oligoanuric and was on alternate day dialysis, and both of them were continued. On other routine investigations, to rule out secondary causes of infection, sepsis, and blood culture came out to be sterile, urine culture sensitivity sterile, serum procalcitonin was normal, tropical profile dengue malaria was negative, ruling out the tropical causes for AK. And special investigations, C3, C4 were normal and serum haptoglobulin were low, with DCT, ICT being negative and coagulation profile, PT, APTT, INR being normal. And plasmic score we calculated just to rule out the called possibility of TTP that revealed the patient was actually in low risk profile. So, diagnosis of acute kidney disease with fluid overload, hypertension, likely due to TMA with fluid overload, and strong suspicion of TMA possibly being gemcitabine induced was kept, as patient had normal C3, C4, haptoglobulin levels were low, and patient had raised LDH with the progressive worsening of anemia and thrombocytopenia. A possibility of drug-related TMA was kept, but a possibility of crescentic GN or drug-induced ATN could not be ruled out. So what's next? We plan for stabilization and early renal biopsy in this patient. As you can see, patient presented to us with a weight of 82 kgs. HB at that time was 8.5, platelet of 1,20,000. At that time, we initiated the patient on hemodialysis on alternate day basis. Initially, patient was given continuous dialysis for early stabilization of the fluid overload, and 3-unit PRBCs were transfused. Over the time when patient actually got stable, we planned for renal biopsy. But before that, we had to initiate the patient on steroids as platelets were on the falling trend, and a possibility of drug-induced ATM was also one of our differentials. Renal biopsy after stabilization at the earliest was done on 29th of Jan, day 10. Following that, hospital course, a medical oncology opinion was taken, and it was advised to follow up in the oncology OPD with PET CT, as PET CT of October 23 was suggestive of almost complete resolution of the liver lesions. In light microscopy, 16 glomerulus, out of which 3 were globally sclerosed, and all the glomerular revealed ischemic changes, including mesangiolisis, wrinkling, like we can see here in 4 and 5 o'clock. As you can see on 4 and 5 o'clock, there is mesangiolisis, wrinkling, and secondary sclerosis of the capillary tufts. Since we have caught the disease in the early course, there is no glomerular shrinkage in the biopsy. There is a presence of intracapillary thrombus, and no crescents or tufts necrosis was observed. In tubules, normal cytoplasmic vascular changes were observed, and IFTA, as you can see here, is almost minimal, 10 to 15%, ruling out the chronicity of the disease. In vascular compartments, few arteries and arterioles reveal vessel fibrinoid necrosis and luminal thrombotic occlusion, making a diagnosis of TMA. As in immunofluorescence staining, all the complements and immunoglobulins were negative, ruling out the immune-mediated and the congenital disorders, congenital causes for TMA. In renal biopsy, overall impression was widespread vessel wall involvement with necrosis and RBC fragmentation, and luminal thrombotic occlusion suggestive of TMA, with the glomerular revealing severe ischemic changes. DF was negative or significant immune and complement deposits. So we reached to final diagnosis of acute kidney disease, like we have kept earlier, in a patient with metastatic carcinoma pancreas, etiology now being thrombotic microangiopathy, probably drug-induced TMA, the drug being gemcitabine. Now, before actually labeling the final diagnosis, we had two differentials, whether it is either drug-induced or tumor-related. Points favoring the drug-induced was gemcitabine, as the cumulative dose of gemcitabine was over the toxic range, more than 25 grams per meter square, and it was associated with severe hypertension and hypertensive urgency and flash pulmonary edema to the start with, which is more commonly observed with the drug-induced TMS. Points against tumor-induced TMS were that usually in the initial presentation of solid organ malignancies, it is presented at the onset of the disease, and it is associated with disseminated malignancy. And since patient was responding to chemotherapy earlier, so that possibility was ruled out. And the thrombotic events in malignancy, they're usually systemic, not renal limited. So, and there was no deranged coagulation parameters in this patient, that was also favoring the drug-induced being the common reason rather than tumor-induced. Now, for the management of drug-induced TMA, initially we recognized the TMA. We had all the parameters of increased LDH, increased bilirubin, and retic count. Retic count was 12% to start with, then we had low haptoglobulin, and COMBs were negative. And there was a damage, organ damage for sure. And we excluded the DIC with normal coagulation profile, although NMTS levels couldn't be done. And secondary TMAs like autoimmune disorders and malignant hypertension, that was ruled out. So, keeping up for a possibility of DI-TMA, the management was divided into two parts. If it is being tumor-induced, which was less chances, which was a less of a possibility, medical oncology opinion was taken, and patient was continuing on adequate supportive care. For drug-induced TMA, the first thing was the removal of the fending drug, which was done before our presentation, and supportive care was continued. Now the question was what to consider next. Should we consider PLEX, steroids, or other modalities of treatment available? Now, management of DI-TMA as per the American Society for FRS's 2019 guidelines clearly suggests that in category 1, the ticlopidine, there is FRS is accepted as a first-line therapy. And for drugs like clopidogrel, it is accepted as a category 3, in which the role of FRS is not yet established. But the drugs like quinine, which is the most common cause of drug-induced TMA, and gemcitabine, the second most common cause, there is a published evidence which demonstrates or suggests FRSs can be ineffective or harmful. But 4. Since in our patient, the drug-induced gemcitabine and antibodies against gemcitabine could not be tested because of the logistic issues. We had to give the patient benefit of doubt. And on 2nd of the Feb, and patient on biopsy was clearly showing TMA with almost all the glomeruli involved. We had planned the patient for plex, and steroids were stopped since there were no immunoglobulin or C3 deposits on the biopsy. In hospital, we have given 4 sessions of plex alternate day, and post plex we can see there was an increase in the hemoglobin levels, and LDH started to fall. Initially, LDH was 11,000 and retic count started to stabilize. Initially, it was 12%, and bilirubin normalized. On day 21, 4 cycles of plasmapheresis were done, and patient was still anuric on single antihypertensive, and weight now patient had of 70 kgs initially to 82 kgs, and there was improvement in LDH and retic count stabilized. But next issue was the platelets were on a falling trend, for which the possible causes of DIC was kept. Initially in carcinoma, DIC as a part of pancreas was kept, but ruling that out was again repeated normal coagulation profile. Although D-dimer this time was slightly on the normal side, but that's a non-specific once the EGFR is less than 5. And fibrinogen levels are on the lower side, and normal being 150. And clinically, there were no signs of infection, and procalcitonin repeated again on 9th of Feb came out to be normal. Now, the third possible cause kept was drug-induced TMA, could be disease-related. For that, trial of Rituximab has been planned. On day 24, post-plex, we can see patients now current status, yesterday's status. HB is 9.7, TLC is 14,000, and platelet is 60,000. This is because in between the post-plex, we have started the patient on steroids, keeping a possibility of immune dysfunction, which couldn't be ruled out as we are not getting gemcitabine-induced antibody levels or not couldn't be done. What will be the further options for the patient? As the patient continues to be anuric, we are planning for right IJV tunnel catheter as soon as we had a chance, and till the patient recovers, or if not. And some case reports have shown that actual effect of injection Rituximab, a trial which can be given to a patient after explaining due risk and prognosis. And for chemotherapy, the patient medical oncology team will make the decision. Now, for discussion, ruling out causes of TMA. First, Adam.
Good morning, everyone. So we have presented a case of probable gemcitabine-induced TMA. Although the clinical presentation was very strongly putting out that this is a thrombotic microangiopathy, we had severe anemia, thrombocytopenia, raised LDH, low haptoglobulin, raised retic counts. The hematological picture was suggestive of TMA. Alongside, there was severe hypertension, which is commonly associated with renal involvement in TMA. And the renal biopsy further supported our diagnosis that aggressive TMA with involvement of all the glomeruli. Ischemic changes were observed in each glomeruli. And there were no immune deposits in the DIF. So what these immune deposits negativity favors is that there was no atypical HUS component in this patient because there was no C3 deposition in the biopsy, and also the serum C3, C4 levels were normal. So we ruled out that genetic component of TMA, atypical HUS. Regarding the possibility, now we will be discussing in our further discussion with gemcitabine how it causes actually TMA. It can be immune mediated, can be non-immune mediated. We are strongly suspecting non-immune mediated as the cumulative dose is 37.9 grams, which is way higher, and it is reported in the case reports. However, as we are managing this patient, we are also observing something else, that is platelets are falling despite of giving him plasma exchange. That plasma exchange actually is a therapeutic trial also for the 18-13 levels that we have not been able to do. If the patient was having those blood deficiency, the plasma exchange would have helped him. So that it rules out that there is less likelihood of 18-13 deficiency. Now, Okay, before I go further, are there any queries in the house which you want to ask? Then I will explain regarding the rest. Queries is going to discuss it.
Yeah, I think it's a very well worked up case and clearly shows that gemcitabine toxicity is there, but what was the mechanism of gemcitabine that he's going to discuss. So gemcitabine, normally 22 grams per meter square is the dose, and you clearly said that it is high, but how it, and also gemcitabine was given for 7 months. So you all worked it up very well. What is the cause of, but clearly shows gemcitabine toxicity, but what is the mechanism of gemcitabine toxicity? Because it is a cause. 20% of patients on gemcitabine do have nephrotoxicity, but that the other things we'll listen to and then we'll make a comment.
In causes of TMA, we'll be discussing first the ADAMTS13 deficiency causing TTP, which was ruled out in the patient since there was no fever or neurological symptoms, and next being the complement mediated. Since there was no complement deposits in the biopsy and serum complements were also normal. Keeping drug-induced TMA, gemcitabine being one of the causing agents, and also we ruled out autoimmune diseases like SLE, EPLA, IgA, and chiroglobinemia. Next, in infection-induced TMA. Infection-induced TMA, we ruled out, since history was not suggestive of any infective episode, that was ruled out. And in metabolic causes, G6PD and B12 levels ruled out. And now, the mechanism of drug-induced TMA, there are two mechanisms. First is the immune mechanism, in which we distinguished drug-induced TMA from drug-induced TTP based upon the normal ADAMTS13 levels. In drug-induced TMA, antibodies are usually dependent on the presence of drug or any of its metabolites. The antibodies may react to platelets, neutrophils, or endothelium cell, causing the endothelial dysfunction. And the management in this part is usually to discontinue the drug and permanently discontinue the drug, even for the future use, and associated future care, supportive care with PLEX, which has to be initiated if TTP is suspected or confirmed, with ADAMTS13 being less than 10%. In non-immune mechanisms, toxic drug effects may directly lead to endothelial dysfunction and increased platelet aggregation, causing excess activation of the complement proteins and clotting factors. In that case, the management is again to discontinue the drug, provide supportive care, and complement blockade may actually help in severe cases, but the evidence is not that supportive. And future challenges with the dose reduction may be considered when benefits actually outweighs the risk. The reported causative drugs are most commonly quinines, trimethoprim, sulfamethoxazole, fluoroquinolones, metronidazole, famciclovir. And the drugs which are actually in both of the immune mechanism, culminating in both immune and non-immune mechanism, is gemcitabine, both causing immune and non-immune mechanism. Now, gemcitabine is a pyrimidine analog, and pathophysiology of gemcitabine-induced TMA is that direct endothelial damage is observed when the cumulative dose is more than 20 grams per meter square, which was clearly in our case was 37, and in presence of drug-dependent antibiotics and alternate complement pathway dysregulation, which was ruled out. In our case, cumulative dose of gemcitabine was 37.8 grams, and there was no evidence of complement pathway dysregulation. And drug-dependent antibodies as test was not available, so the possibility of immune-mediated mechanism cannot be ruled out. Now, this is the largest cohort study done by David et al., suggesting the thrombotic microangiopathy associated with gemcitabine use and presentation and outcomes in a retrospective cohort. Total 120 patients were taken in this study, and there was a cessation of gemcitabine done in all of the patients with the routine use of antihypertensives in around 57% patients, and plasma exchange was done in 39% of the patients with the use of FFP and use of steroids in 15%, and eculizumab was used in 5% of the patients. And it was found that complete remission, including renal and hematological remission, was observed, and there was no significant difference between the PLEX and non-plex candidates, and p-value was more than 0.5. And in hematological remission, again in plex patient, the hematological remission was observed in 21%, and patients which were not given any plex was around 29%. And absence of remission was observed in patients with plex in 39%, and patients with no plex around 25%.
Plex being plasmic.
Plasmic. Now, what were the other treatment options for patients with thrombotic microangiopathies? First, the immunosuppressive agents, usually a dose of prednisolone continued and probably effective in patients in addition to plasma exchange in patients with TTP or anti-ADAMTS13 autoantibodies or in atypical HUS with anti-factor H autoantibodies. The next being the CD20 cell depleting agents like Rituximab and a standard dose of 375 milligram per meter square per week as long as we have adequate CD20 or CD19 cell depletion. And FFPs in usual exchange, plasma volume 1 to 2 plasma volume per day is exchanged, which is a first line therapy for TTP. Although unproven efficacy in childhood onset typical HUS is there. And usual infusion of FFP at a dose of 20 to 30 ml per kg, which is followed by 10 to 20 ml per kg per day. The next available agent is Caplacizumab, which is usually given at a dose of 10 to 11 milligram IV loading dose, followed by the same dose subcutaneous, daily combined with plasma exchange and immunosuppression. But in all of the treatments, plasma exchange remains the first line of modality. And liver and kidney transplant is done in patients with atypical HUS, congenital atypical HUS. And the complement inhibition with Eculizumab is usually given at a dose of 900 milligrams per week for first 4 weeks, followed by 1500 milligrams every 14 days up to 6 months, which is a first line therapy for primary atypical HUS. There have been certain case reports where there is improvement of gemcitabine induced TMA with Rituximab. That was a single case report in a patient with ovarian cancer. And in that, it was found that Rituximab was actually started after lack of clinical response to plasmapheresis, just like in our case. And there was partial renal recovery which was observed. Prior to the drug-induced TMA, patient had normal renal function, and even after full therapy with plasmapheresis and Rituximab, only best GFR, eGFR which was attained by the patient was 28 and serum creatinine of 2. And mechanism of action which was proposed was the depletion of B cells, which may actually reduce the production of B cell dependent cytokines that actually derive the endothelial dysfunction. Now, a message from our case is like drug-induced TMAs is potentially life-threatening disease and usually accounts for 10 to 13% of all the TMAs, of which gemcitabine accounts for around 2% of all the cases. The potential rapid reversal of pathological signs in drug-induced TMA depends upon the early suspicion, recognition, and discontinuation of the potentially offending agent to reduce the organ damage. And in severe drug-induced TMA, cases not responsive to drug withdrawal, the use of plasmapheresis and Rituximab can be considered as a rescue therapy. However, no prospective studies supporting the efficacy of these treatments is available in drug-induced TMA.
But at present also the patient is admitted. His renal prognosis is although very poor. There is very less likelihood that his glomeruli are going to recover. They are not going to recover. Only thing, the trials of Rituximab and everything we are giving is for his hematological remission. As he is going to be on chemotherapy after this also. So, like we said, that those gemcitabine induced antibodies which act against the endothelium and the platelets both, and in turn predisposed for TMA. So this platelet falling now at present after plasma exchange could be one of the actions of that immune mediated mechanism, direct effect of those antibodies on the platelets. So everything that we'll be trying now will be for his hematological remission, but his renal prognosis overall is very poor. He is likely to be dialysis dependent.
Though I'm no expert on any of the conditions that this patient is suffering from, right? Pancreatic cancer as well as renal failure. But you mentioned during the course of your presentation that you started this patient on steroids and you stopped them because you could not get the antibodies to gemcitabine and you were not sure whether this is immune mediated. But in the course of your presentation, you also say that there was a patient who responded to Rituximab, and there are patients in which steroids are given. And I think your case also, you're still contemplating, whether steroids should be given. So I was wondering whether you should be giving steroids to this patient.
For 4 weeks, a short course of steroids.
Because you've already stopped it.
Yes,
So since this round is for, discussing about possible for drug-induced TMA, where IVIG can be used, I just wanted to have an opinion on that.
Very less. As far as the literature that we have reviewed, we have not seen IVIG to be directly used in drug-induced TMAs. So again, that will be an experimental therapy from our side, because plasma exchange and IVIG are considered combined in those treatments. So we have to search for more literature, but we searched, we could not find anything on IVIG. Only things for plasma exchange, Rituximab and the Rituximab, which is a C-type inhibitor, which is a very costly drug, not available. But these were the only drugs which we found.
It's really a good case. I think what interested me was that the common antimicrobials which we use and which can predispose to this type of complication. My one question is that, is there any role of N-acetylcysteine in management of this drug-induced TMA? Is there any possibility?
N-acetylcysteine's mechanism will be different, and generally it is used to prevent contrast-induced AKI. That also, because N-acetylcysteine is not either going to prevent the formation of new antibodies or even remove the formed antibodies, preformed antibodies. So less likely that N-acetylcysteine will be.
Okay.
Good morning, ma'am. I am from Hematology Department. To add to the point of N-acetylcysteine, ma'am, N-acetylcysteine has been used in cases of refractory TTP, not in TMA, like not in atypical HES. N-acetylcysteine will break the disulfide bonds of the the protein. So the ultra large multimers will not be formed. So there has been a role and trials of N-acetylcysteine in TTP cases, proven cases, that too relapsed refractory, not responding to PEX or the first line treatment. Also, there has been reports of drugs like proteasome inhibitors like bortezomib, that also in TTP, not in this case. Definitely, in our literature search also, no cases were found where N-acetylcysteine was tried in gemcitabine induced TMA.
Because the mechanism of action of both the things are different.
Yes, sir.